Hey everyone, and welcome back. Today, we're jumping right into part 87 of our Medical Coding Masterclass. This explainer is fully dedicated to mastering special evaluation and management services, specifically CPT codes 99450, 99455, and 99456. So, if you've ever found yourself a bit confused about how to properly bill for basic life insurance evaluations, disability assessments, or those tricky work-related injury exams, you are in exactly the right place. Let's get right into it.
Today's agenda is packed. We're going to cover the scope of these evaluations, the mechanics of code selection, the strict rules around treating versus non-treating providers, exactly what documentation you need, and of course, how to avoid those top audit red flags.
All right, let's start with Section 1, the scope of special evaluations.
So what exactly are we talking about here? To figure out how these special codes differ from your everyday standard EM visits, we really have to look at the intent. These encounters aren't prompted by a patient walking into the clinic feeling sick with a chief complaint they want you to fix. Instead, think of these as third-party data gathering missions. A third party, like an insurance carrier, an employer, a state disability board, or maybe even legal counsel, has specifically asked for this evaluation. They just want to establish a baseline. They need to know things like, is this person eligible for basic life insurance? Or, what is the precise medical status of this work-related injury?
And here is the absolute golden rule, literally the crux of the whole thing. No active management of the problem is undertaken during these encounters. Zero. It is all about separation. You are there to gather baseline info, full stop. If you're prescribing new medications to treat the condition or doing active, ongoing therapy, you've crossed the line. Those actions are completely excluded from the intent of this specific service. Basically, you're there to evaluate and report, not to treat.
Moving right along to Section 2. The mechanics of code selection.
Picking the right code basically boils down to a simple logic tree based on two things: the purpose of the exam and who's doing it. If the exam is for basic life or disability insurance and it's done by an independent doctor, so someone other than the patient's usual treating physician, you're going to go with CPT 99450. Pretty straightforward, right? But if the exam is for a work-related or medical disability, you have to ask who is actually performing the exam. If it's the patient's own treating physician, boom, that's 99455. However, if that exact same work-related disability exam is done by a non-treating provider, what we usually call an independent medical examination, or IME, then you hit them with a 99456.
Now, when you look closely at the CPT guidelines, specifically for 99450, it gets highly detailed. Since this is usually for life insurance, the code actually requires you to collect blood and urine following incredibly strict chain of custody protocols. Plus, you've got to measure their height, weight, and blood pressure. You're not just doing a quick look over, you are fulfilling a very rigid administrative and medical checklist.
Which brings us to Section 3, the massive difference between treating and non-treating rules.
There is a huge fundamental divide here, based entirely on the provider's status. Let's say you're the treating provider using 99455 for a work-related disability exam. Your documentation absolutely has to reflect that ongoing relationship. You actually have to formulate a diagnosis, formally assess the patient's capabilities, calculate their impairment, and, this is key, develop a future medical treatment plan. On the flip side, if you're an independent, non-treating examiner using 99450 or 99456, you are strictly there for an objective assessment. You are not establishing a long-term care continuum. You step in, you evaluate, you step out. And I really need to drive this point home. If the provider starts managing prescriptions, tweaking dosages, or actually treating the patient's acute symptoms during this exam block, those therapeutic services are entirely excluded from the special E&M codes. You absolutely cannot bundle routine disease management into these administrative evaluation codes. Now, if totally separate, medically necessary E&M services happen on the exact same day, they'd need their own distinct code billed additionally. But the special E&M itself, zero active management, period.
All right, Section 4, let's talk about documentation and reporting.
What exactly needs to be sitting in that patient's chart to confidently bill these codes? Well, a quick, messy scribble definitely won't cut it. You've got to check off some major boxes. You need hard proof of a comprehensive review of past medical records. You have to include those completed, super detailed disability rating forms. You also need to document a functional capacity assessment, a thoroughly objective physical exam that matches the patient's condition, and finally, the actual submission of a formal medical report.
And, the workflow for that final product is totally different from a normal visit too. With a standard office visit, your progress notes just sit internally, maybe they get pushed to a standard primary care portal for the patient to see. But the output of a special EM is a highly tangible product. It's a formalized medical certificate or report that gets shipped directly to the requesting third-party entity. That employer or insurance carrier or state board is literally waiting on this exact document so they can make their administrative decisions.
Finally, let's wrap up with Section 5 and look at the top audit red flags you desperately want to avoid.
As a coder or biller, you've got to set up strict guardrails against these massive traps. Number 1, never ever report standard office E&M codes like your 99202 through 99215 when the entire point of the visit is a life insurance or disability evaluation requested by a third party. Number 2, do not co-bill routine treatment alongside special E&M codes unless there is a completely distinct medically necessary issue being managed, and honestly, even then, tread incredibly carefully with your documentation. Number 3, never use 99455 for a run-of-the-mill workers' comp follow-up visit where you're just checking on a healing sprained ankle. Remember, 99455 is for the formal disability or impairment evaluation. And number 4, always make sure the formal third-party request for the exam is actually sitting right there in the medical record.
I'm going to leave you with this ultimate rule straight from the CPT guidelines, which perfectly nails the whole intent of these codes. When using these codes, no active management of the problem is undertaken during the encounter. If you just let that one sentence guide your code selection, you are going to stay right on the safe side of compliance.
So, I really want you to take a hard look at your clinic's charts today. Are your providers accidentally mixing up active treatment with third-party data gathering? It happens way more often than you think. Make sure your documentation clearly separates these distinct services to protect both your revenue and your compliance status. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.